Hello, everyone. Thank you for joining us today. I see a lot of you coming in from the lobby, so I'm going to give it to the top of the hour to get us started. We've got some great information to cover today, and I'm so happy you're here. And I'm really cold. All right, I do see a lot of people still in the lobby, but I'm going to go ahead and get us started. Hello, everyone, and welcome to the Rural Health Executive Educational Series. I am Cody Smith, and the Director of Rural Partnerships with NRHA Service Corporation, and I will be moderating for you today. Before we jump in, just a few quick things to know, and I know a lot of you have heard this before, but just some good reminders. This session is being recorded, and you will get a link in your inbox later today. Please feel free to rewatch or pass it along to anyone who you think will find the information useful. There is a quick survey at the end of the session. I really do read all those, I promise. I know I ask you all the time, but your feedback is so important to me. It does help me keep these sessions relevant and useful. So thank you so much in advance for filling that out. Couple housekeeping items. Everyone is muted. This is not judgment. You guys know I love you, but it's how we keep things running smoothly. The presentation will last anywhere from 30 to 45 minutes. This will be allow for some time at the end for question and answers. So if something sparks a question, please don't wait. Go ahead and drop it into that question box whenever it comes to mind. Our speakers are here to help, and I know they'd love to hear from you. So with that, let's meet our speakers. Today we have Dr. Scott Belliston. He's a fellowship-trained neuroimmunologist. I can talk, you guys, I promise. He specializes in multiple sclerosis care and works closely with rural providers to support early recognition, referral, and management of complex neurological conditions, helping improve access to specialty expertise in underserved areas. We also have Dr. Michael Markowski. He's a general neurologist with more than 20 years of clinical experience and a national leader in neurology workforce development. He focuses on strengthening general neurology capacity and expanding access to specialty care, all critical issues for rural communities facing provider shortages. With that, I'm going to go ahead and turn it over so we can get started today.
Thank you. Good afternoon, everyone, and thanks for joining. We'll go ahead and go to the next slide. Today we're going to talk about multiple sclerosis and recognizing common presentations and care in the rural health setting. Next slide. And go to the next slide. First, we're going to start off with a poll question. Just wanted to see how many of the participants are currently seeing patients with multiple sclerosis and how many they have.
Thank you so much. I'll leave that open for a little bit. Thank you, everyone, for taking time. If you could just go ahead and vote on that poll, I'd appreciate it. And then I'll make sure we share the results. We can see some commonality amongst us, I think. All right, I'll leave it open for a couple more seconds. All right, I'm going to go ahead and share those results with you now.
All right, thank you for everyone that participated in that. So it looks like we have quite a few people, about a third, that see more than 9 or 10 patients, and then another third that aren't currently seeing, and then a little bit of in between. All right, let's go to the next slide. So today we're going to talk about why an early diagnosis of multiple sclerosis is so crucial. And it's because the earlier we diagnose multiple sclerosis, the better the prognosis. Currently, we have quite a bit of our patients that live in rural areas and what we would call an MS specialist desert. And only 13% of those in rural counties have access to a neurologist. And this means that primary care has to be the ones to recognize the early symptoms and signs of MS and make that early diagnosis, or at least get the ball rolling. Next slide. So this is my outline here. We'll go through a few cases intermixed with some education about multiple sclerosis. Next slide. So our first patient is a 26-year-old Caucasian male who had sudden onset of dizziness and disorientation while at work. While this isn't a common presenting sign of MS, he did get an MRI from his primary care without contrast, and it did show multiple lesions that could be seen in a demyelinating disease. So a referral was made to neurology, and he was seen in my clinic about 5 months after his initial MRI. Next slide. So we'll come back to him in a minute, but first we're going to talk about when you get an MRI that comes back abnormal. What do we do next? So while not everyone who gets an MRI, the brain will need to have it done with and without contrast. If we are concerned about demyelinating disease, contrast helps us see if there's any disease activity. Lesions that have contrast enhancement will be present on MRI for about 4 to 6 weeks, and that helps us in diagnosis if they're present. Gadolinium is safe in screening for multiple sclerosis for the majority of our patients, as long as their renal function is good. For patients who have received many MRIs over the years, such as our patients with multiple sclerosis, there is some gadolinium retention, but has been asymptomatic as of yet. So while we do keep that in mind with the number of MRIs we get with contrast, they have not caused any known symptoms from that. Next slide. So back to the patient, he came in and was very anxious about the possibility of having multiple sclerosis, and this was particularly worsened by the long wait to get in to see me. As his MRI was suspicious but not textbook, I went ahead and repeated an MRI brain with and without contrast, and also obtained imaging of the cervical and thoracic spinal cord. These were important tests as I mentioned, enhancing lesions significantly aid in the diagnosis, or if there's spinal cord lesions, the diagnosis is much more certain, and many patients will not need a confirmatory lumbar puncture at that point. We also got a vitamin D level, and we'll discuss this a little bit later. But these are all things that can be done while waiting to be seen by neurology. Next slide. So talking about what is multiple sclerosis, it's an autoimmune disorder where the primary target is the myelin coating around the nerves of the central nervous system. MS does not directly affect peripheral nerves or their myelin sheath. This is why an MRI of the lumbar spine is not necessary when working up for multiple sclerosis. Next slide. MS is still a clinical diagnosis based on history and physical exam, but we do have a lot of paraclinical tests that help aid in the diagnosis, including MRIs, optical coherence tomography, which measures the thickness of the retina and the optic nerve, can show evidence of prior optic neuritis, or visual evoked potentials, which can also help aid in diagnosing visual complaints that can happen in MS. And then, of course, spinal fluid can be helpful in aiding in the diagnosis. Mostly, I'd like to highlight that a more likely diagnosis has been eliminated or excluded at this point. Next slide. So, as I mentioned, one of the paraclinical tests is MRI. Here we have images of normal MRI on the right, and then on the left we have a typical MRI of the brain with periventricular lesions that are radiating out from the ventricles, what we would call Dawson's fingers. And then we see below that spinal cord lesion, and this is post-contrast, showing that as an active lesion and enhancing that. And again, if we see something like this, it does help significantly make the diagnosis more certain, and with the new diagnostic criteria, many patients will not need lumbar puncture. Next slide. Okay, so our next polling question is, how can primary care support patients with multiple sclerosis?
Thank you, everyone. I'll leave this open a couple, I don't know, 30 seconds or so to get everybody's vote. I'll leave it open just a little bit longer. It looks like a lot of the same answer here, all of the above so far. So I do see quite a few people still voting. All right, I'm going to go ahead and share those results with you. Thank you, everyone.
All right, thank you for that. Yeah, so all of the above, and we'll go over these different things that help in caring for someone with multiple sclerosis, and why each of these things is incredibly important, including early recognition and referral to neurology. Next slide. We'll talk a little bit about the epidemiology. While it's most common in women, it can affect both men and women. It typically presents in the 2nd through 4th decades of life, but can happen in pediatrics as well, and as well as older adults. Most recent study of patients with multiple sclerosis in the United States indicated that there's nearly 1 million patients affected. A delay in diagnosis, as I mentioned earlier, or poor access to healthcare are both associated with worse health outcomes in multiple sclerosis. Next slide. We'll talk about another patient of mine who's a 50-year-old Native American male who presented with worsening of gait for a few months. On further questioning, he notes that 3 years ago he had left leg numbness for about a week that then gradually improved. An MRI of the brain was done and showed multiple lesions concerning for multiple sclerosis. He unfortunately was delayed in starting on treatment due to his own concerns about possibly not having multiple sclerosis, as well as his personal concerns about risk of treatment. I bring this case up because he's not the typical MS diagnosis that we think of, being male, a little bit older, and of a different race. And so we'll go to the next slide. Here we see another one of his MRIs. He had another relapse, and this time had bilateral lower extremity weakness. At this time, he was convinced and did start on teriflunomide. Unfortunately, he had continued weakness in the legs, and this has led to a lot of increased falls. His most recent fall did result in a clavicle fracture that required surgery. Next slide. So, as we mentioned earlier, recognizing the signs or symptoms of MS are crucial early on. Here we have demonstrating some of the presenting symptoms and the location of the brain where the lesions are determine what presentation or their symptoms they may have. Next slide. Here we'll go over a couple of the presenting symptoms. So unilateral vision loss with pain with eye movements. This is optic neuritis, and double vision with both eyes open is typically an internuclear ophthalmoplegia or brainstem lesion. Unilateral weakness with numbness or ataxia is also brain or brainstem, and then bilateral weakness or numbness or ataxia if there's a sensory level in bilateral symptoms. We typically think of transverse myelitis. For symptoms to be related to an MS lesion, they should last at least 24 hours and typically improve over weeks to months. So transient symptoms that come and go less than a day are very atypical or unusual for new MS lesion or an attack. Next slide. We'll go to the next slide as well. We have a few to kind of jump through here. And my computer just locked me out. So apologize about that. Okay, apologize. We can go forward a couple more slides there. And to the next one. There we go. Our next patient is another Native American young female who came in for possible multiple sclerosis. She had a lot of things going on when I saw her, including bilateral vision loss, gait instability, and a band-like tightness around her waist with bowel and bladder urgency. She had not yet had any imaging, so I sent her immediately to the hospital to expedite her workup and to start her on treatment with high-dose steroids and plasmapheresis. So these treatments significantly helped her symptoms, and then she was started on a B-cell depleting medication without any further relapses or progression of symptoms for over 2 years now. Next slide. Choosing a disease-modifying therapy, this is typically a pretty detailed discussion that we have in clinic where we do shared decision-making of risk and benefits. And now we have many different options for treatments, over 20 FDA-approved medications for relapsing remitting MS. Some of them are oral, self-injectable, and even infusion therapies. But the most important thing is getting the patient to be part of that decision making, and this will help them stay compliant to their med and to get the best results out of it by them actively participating in their care. Next slide. So it can be a little overwhelming to have so many medications available. The key thing is you don't have to know or remember all of them, but know that there's resources out there like the National MS Society. They have a great web page where they can help you or your patients in knowing how to recognize MS or the different treatments available, and how to even find doctors or resources available to them. Acute treatments include high-dose steroids, as you know, and plasmapheresis. Oral prednisone has shown to be as effective as IV solumedrol when given at a high dose, and may help those with limited access to being able to get IV steroids. Next slide. Wellness in MS. This is really important, not only just getting them on a correct therapy to stop relapses, but getting them therapies that will help them live a more healthy, active life. Smoking, as was alluded to earlier, has shown to actually increase the risk of developing more MS lesions, attacks, or progression. Likewise, a low vitamin D level can be associated with a higher risk for relapses and worsening disease. And then we have a lot of symptom management available, particularly therapies, but many medications. And this is something that primary care can certainly help out with as well, and getting these medications and therapies balanced for them. Next slide. Here are just some of the other resources available from the National MS Society. Probably the one I love the most is the MS Navigators. These are highly skilled, trained professionals that are available by phone or chat, and they help people with newly diagnosed MS versus those that have had MS for a long time, with the community resources and things that they need. And a typical phone consultation to an MS Navigator can last up to a couple hours. So they really take the time to listen to the patient and educate them. And so, again, this is a free service that's through the National MS Society and available to patients and their families and friends. With that, next slide. This will conclude my portion of the webinar.
So before we move on, I know I said we were not going to do it this way, but just because this is a very specific question, Dr. Belliston, a question came in about case study number 2. Did they get a referral for physical therapy to try and reduce the fall risk?
Yes, and I think that has helped him some, and definitely has continued to work with physical therapy. Very good question.
Thank you. All right, perfect.
Shifting gears now. Well, welcome everyone. Thanks for joining us on a busy afternoon, and thank you, Dr. Belliston, for that Excellent presentation. We can move on to the next slide. Well, there was an introduction at the beginning. I'm a general neurologist, a comprehensive neurologist in Cape Cod, Massachusetts. I've been here for over 20 years, and I care for a lot of patients with Parkinson's disease that I'll be speaking about today, MS and other disorders. Next slide. So we're going to start with a polling question. So what are the biggest challenges you experience in diagnosing Parkinson's disease?
Thank you. I'll leave that out so everybody can vote. So what are the biggest challenges you experience in diagnosed Parkinson's? I cannot.
So around a third, pretty even, or maybe a little more lack of familiarity with diagnostic criteria. So we'll be discussing all of these over the next 20 minutes or so.
Wonderful. Thank you so much.
So next slide. So as I mentioned, I'm not a Parkinson's specialist. I have been practicing for over 20 years, and as you see here, most patients with Parkinson's disease do not receive their care from a Parkinson's or movement disorder specialist. I'm very grateful to Dr. Albert Hung, my colleague at the Massachusetts General Hospital. He is a Parkinson's specialist, and he provided a lot of these slides today. But this rings true for, I would bet, almost every neurological disease, where with MS, hopefully, there's a higher proportion of patients receiving care from Dr. Belliston and his colleagues. But for tremor, for neuropathy, for Alzheimer's and dementia and stroke, the vast majority of the 1 in 2 Americans with the neurological disease or disorder receive their care from a general neurologist, a primary care provider, more so than a subspecialist in that area. And when we look at Parkinson's disease data from the Parkinson's Foundation, there's currently 660 Parkinson disorder, movement disorder specialists in the US, only 6 of whom are practicing in rural areas, like where Dr. Belliston practices, and even myself, kind of suburban in Cape Cod, Massachusetts. Next slide. So this remains a clinical diagnosis. So now we're going to talk about more diagnostic criteria. So the hallmarks of Parkinson's disease and Parkinsonian disorders are slowness of movements, rigidity, rest tremor, and with time, sometimes earlier on, but usually as it advances, more postural instability. So this remains a clinical diagnosis. We do have other diagnostic tests that are supportive, but it still remains a clinical diagnosis. Next slide. So oftentimes what I'm seeing when the patient first presents or they're first referred is the tip of the iceberg, right? I'm seeing the rest tremor, the slowness of movements, I'm feeling the rigidity and the cogwheeling, but there's so much more that goes into this disease. Many of these symptoms start 10 to 20 years before the motor symptoms, loss of smell, sleep disturbances, constipation. All of these can be 10 to 20 years before they start with the more classic motor symptoms that I just covered. Softness of speech, smaller handwriting, and then low blood pressure leading to dizziness. Next slide. So expanding on that further, this is really a great slide showing timeline, right? A lot of these patients are seeing a provider at time 0, or sometimes they're 5 to 10 years into their disease. In hindsight, when I'm asking the questions about when that tremor first started, or when their spouse noted they weren't swinging their arm very much when they were walking. But the constipation can be 20 years before they start with motor symptoms. REM behavioral disorder, acting out their dreams, vivid dreams. Patients and their bed partners will oftentimes mention loss of smell, depression, again, decades before the classic motor symptoms. And oftentimes, like with MS, we're seeing people too late in the disorder when it would have been more helpful starting treatment earlier on. Next slide. So we've had a pretty good idea of the pathology of Parkinson's for a long time. The central defect is loss of dopamine from the basal ganglia due to degeneration of the substantia nigra not making enough dopamine. Lewy bodies are made up of alpha-synuclein, among ubiquitin and some other proteins, but mostly alpha-synuclein. And these are seen throughout the brain and the brainstem, but also sympathetic ganglia, dorsal vagal nucleus, the myenteric plexus of the intestines, and the cardiac sympathetic plexus. And that's what leads to a lot of the autonomic and other symptoms associated with Parkinson's. And genetics, we'll look at that a little more now on the next slide. So genetic risk factors account for 10 to 15%. There's higher incidence in certain populations, and we know multiple genes due to gene mapping of over 20,000 patients now enrolled in this one group. So there's both autosomal dominant and autosomal recessive genes associated with Parkinson's. I encourage all of my patients to get involved in this study. The majority of people in this PD gene ration, this gene mapping, have never participated in any type of research trial before. Next slide. So a pathway to Parkinson's, and we can proceed through. If you click it 2 or 3 more times, you'll see some other things pop up. Perfect. So we talked about the genetics, but it's more than just that, right? Only 10 to 15% is genetic. The vast majority of cases are sporadic, idiopathic, and we know there's a large number of environmental exposures that have been attributed to Parkinson's. So epidemiological studies have found exposure to certain pesticides, living in your location, living in urban industrial areas with high release of copper, manganese, lead, farming and agricultural work, living closer to a golf course recently was correlated with a higher incidence of Parkinson's disease, prolonged use of well water, among many others. So genetics plays a role, environment plays a role, ultimately forming these alpha-synuclein deposits in Lewy bodies spreading throughout the brain and nervous system. And then if you proceed one more, that's what leads to the tip of the iceberg and the motor symptoms. So next slide. And then we can move on one more. Thank you. So this is a clinical diagnosis. I diagnose Parkinson's disease routinely with the patient in front of me at their very first office visit. However, there have been some nice advances in recent years in the diagnosis of Parkinson's disease. A DAT scan can be very helpful, a dopamine transporter scan, detecting changes in brain dopamine activity. And when do I use this? If it's classic Parkinson's disease, I don't order a DAT scan. But if someone has Parkinson's symptoms that started and haven't progressed in a long period of time, I'm thinking maybe they have a vascular Parkinsonian disorder, maybe they had a basal ganglia or subcortical lacunar infarct causing these non-progressive symptoms. If someone has been on a myriad of psychiatric medications, the neuroleptics, the antipsychotics, that can cause extrapyramidal syndrome, looking very much like the motor symptoms in Parkinson's, and you're trying to also see whether they have a neurodegenerative Parkinsonian disorder versus this is all medication side effect, a DAT scan can be very helpful, along with some other scenarios. The alpha-synuclein skin biopsy. So it's commercially available, alpha-synuclein, looking both in the CSF, which is really for research purposes, as well as a skin biopsy. And this is commercially available, however, does not differentiate between neurodegenerative Parkinson's and other Parkinson or Parkinson plus syndrome, such as progressive supranuclear palsy, cortical basal degeneration, your multiple system atrophies, among others. And those Parkinson plus syndromes have about a 35% positivity rate. The skin test positivity rate's not very well defined for a lot of Parkinson disorders. I don't order this routinely. I think this lab test is being marketed, though, to the broader physician community. I know a primary care physician practice who's referring patients to me because they had an abnormal alpha-synuclein skin biopsy, and yet they have no Parkinsonian symptoms. So that's something to be on the lookout for. I don't order it frequently, and we're still working on what the positivity rates are. Next slide. Yep, thank you. So pearl number 1, engage the whole family, right? It's the patient in front of us that we're caring for, but ultimately their success or failure depends in large part on their support system. This diagnosis goes well beyond the patient, given a lot of the symptoms that I've mentioned already. So with the cognitive impairment that comes on the moderate to later stages, reversal of your typical parent-child dynamic, loss of close friends given the apathy and depression and withdrawal a lot of these patients have, sexual relationships may suffer, difficulty with housework and being able to continue their job, and the apathy and fatigue that can be so pervasive throughout their life. So this is something where if someone shows up alone their first visit, I'm asking them, hey, when we have that follow-up in a few weeks or a few months, bring your loved one with you, bring your neighbor with you, bring your support system with you, because I want to have this conversation together. Next slide. So another polling question: what is the biggest challenge you experience in treating Parkinson's disease?
Thank you, everybody, for voting. I'm going to leave it up just for a couple more seconds, and then I'll share those results with you.
Yeah, so far a pretty good spread, right? And I'd say almost all the above, right? These are all challenges for me. And co-management with movement disorder specialist, I don't see any respondents there. That is an issue for me. I'm part of the Mass General Brigham system. I live 60 miles from Boston, 60 miles from Massachusetts General Hospital and Brigham Women's Hospital. I cannot get my patients to go 60 miles. So I can only imagine with Dr. Belliston in North Dakota and my colleagues in more rural areas where patients have to drive hundreds of miles to see a specialist. So that's something that is a challenge for me. And frankly, all of these are challenges. Next slide. So pitfall number 2, delaying referrals to rehab services and exercise. When I make this diagnosis, I tell patients physical exercise is just as important as any prescription medication any provider will ever give you to combat your Parkinson's disease. This is so vitally important, especially in the early stages, before they have a lot of postural instability and fall risk, and you have to modify their exercise program. So this is a great study through the Parkinson's Foundation, over 3,000 patients, looking how consistent regular exercise improve quality of life and decrease the rate of their motor function decline. So this was neuromodulating in a way, in that it actually changed the course of their disease. Next slide. So now we're going to talk about medications, and all of our medications for Parkinson's disease are symptomatic. So the holy grail is finding something that is disease modifying and ultimately can restore brain function and reverse neurodegeneration. But all the medications I'm going to talk about now are for symptomatic therapy of Parkinson's disease. Next slide. So these 7 categories of medications, there's only one new since I trained 25 years ago to date myself, but these are all classes of medications that have been around for a long time. The only exception is the A2A receptor antagonist, the adenosine 2A antagonist. That's new in the last 10, 15 years. But these are medications that have all been around for a long time. Levodopa, still the most effective medication. The downside is a short half-life. There's multiple formulations of it, extended release, have more variable absorption, but a slightly longer duration. Then you have the dopamine agonists, and as you hopefully know, there's long-acting forms of pramipexole and ropinirole, and then the Nupro patch, the reticulotin patch, again, options that can last 24 hours, hopefully smooth out motor fluctuations. MAOB inhibitors, when rasagiline was first released, probably close to 20 years ago now, there was one study showing maybe could be modifying the course of the disease and neuromodulatory. Ultimately, that was not the case. This is for symptomatic add-on therapy as well. COMT inhibitors and tacopone in particular to prolong the half-life and duration of levodopa. And then the brand is Neurians for the adenosine 2A antagonist. This has been available in Japan since 2013, approved here in 2019 as an adjunct for wearing off symptoms. And side effects of this are similar to a lot of these other medications: dizziness, constipation, nausea, hallucinations, and in some patients, insomnia. Anticholinergics rarely used with Parkinson's due to the cognitive side effects. And then amantadine can be helpful for add-on therapy for tremor and some motor symptoms, and sometimes to help combat fatigue. Next slide. So this question's been around for a long time. I remember when I was in training and people debating when to start levodopa versus a dopamine agonist. Levodopa remains the most effective drug for Parkinson's disease. Carbidopa-levodopa is Sinemet, so a lot of people are maybe more familiar with the Sinemet term. Available in multiple formulations, dissolving a segmented tablet so you can cut in half. So you can start patients on 1 tablet, then 1.5. And slowly titrate. Dopamine agonists available in intermediate and extended release formulations. Side effects there: nausea, sleepiness, leg swelling, confusion, and impulse control disorders. And I'll describe those a little more shortly. So when do I choose one or the other? For most of my patients, it's levodopa. I live on Cape Cod, where we're the second oldest population of the country, say one zip code in Florida. So I primarily care for an older population. I'm a geriatric neurologist in many sense. So if they have a lot of medical comorbidities or any cognitive impairment, levodopa is preferred. But in younger patients with lower comorbidities, no cognitive dysfunction, starting a dopamine agonist first can be helpful. Sometimes you can prolong or delay the motor fluctuations that inevitably will occur with long-term levodopa use. Next slide. So levodopa, again, preferred. Intermediate release, generally more available than the Sinemet CR option. But for younger patients, women with lower body weight in particular, dopamine agonists can be a great option for initial therapy. Oftentimes, I will start someone on a low dose of levodopa and slowly work my way up, and then I'll add a dopamine agonist at some point, or vice versa, in the course of their disease. If a dopamine agonist is prescribed, one of the unique possible side effects is impulse control disorders. I've seen this in my practice. I always ask people before I prescribe them any history of compulsive gambling, compulsive buying, any OCD behaviors, binge eating behaviors, sexual hypersexuality. These are all things that have to be monitored, and you have to be very frank and ask about before you prescribe this class of medications. MAOBs, rasagiline, among others, can be helpful early on for mild motor symptoms. If someone just has a very mild rest tremor that they're concerned about and want to start something, but you're hoping to delay levodopa or dopamine agonist, rasagiline, even amantadine can be helpful in those cases. And again, always referring to rehab services early and often, telling them exercise is such a vitally important part of treating this disease. And then the importance of diet as well. Next slide. Next slide, please. Thank you. So motor fluctuation. So this is one of the main complications of treating Parkinson's disease over the course of many years. Oftentimes people are in this honeymoon stage after the initial diagnosis where they have mild symptoms. They're progressing very slowly. A lot of the associated symptoms haven't quite set in yet, and they're looking good, they're feeling good, and you're trying to maximize their quality of life at this time, because you know there comes a time when there will be some complications of not just the disease, but also the treatment of the disease. And being on chronic dopamine therapies for many years, primarily motor fluctuations, right? Where you have these on-off times, dyskinesias. The peak dose dyskinesias usually start 30 to 90 minutes after a dose of levodopa. Then the wearing off, the slowness, and the wearing off dystonia, involuntary muscle spasms within the limbs, but sometimes the face and trunk during these off periods. Oftentimes also occurring in the early morning before their first dose of levodopa. Oftentimes when people reach this point, I'll add on Sinemet CR, the more extended release at nighttime, to try to get them through the overnight hour, especially if they have bladder symptoms, have to get up a lot at night to go to the bathroom. And I also tell them, keep your pill box or your bottle near the bedside so you can wake up, you can take your levodopa, and plan to get out of bed 15 to 30 minutes afterwards, when hopefully it's starting to kick in. Next slide. So some of the strategies to manage motor fluctuations, shortening the dosing interval of levodopa. Oftentimes we'll start people on twice daily, go up to 3 times per day. But when they start to have these motor fluctuations, that's when they're going up to 4 times a day, 5 times a day, and they're taking this medication every 2-3 hours, 4 hours on average. Extended release formulations, in particular at bedtime, will levodopa, but the dopamine agonists can be very helpful. The extended release formulations of referrals, pramipexole, or the Nupro patch, these can really be very effective at trying to smooth out with a more sustained release of dopamine. Addition of the COMT inhibitors, Comtan adding to try to prolong the half-life of levodopa, and then Norians, the adenosine 2A receptor antagonist rather, could be helpful in this regard as well. Next slide. So pearl number 2, encourage the patients to take an active role in their care. Again, it's not just exercise importance, but we really want them to be proactive in every aspect of their care. I want them bringing caregivers with them. I think as I get a little wiser, hopefully, being in practice now, I'm better at asking patients, what can I do today to improve your quality of life? And that's really important with Parkinson's and so many other diseases where they have 8, 10, 12 complaints they may have on a list. And you try to work your way through all of their concerns and complaints over your 30 minutes or 40 minutes or hour, or sometimes 10 minutes, however long you may have with them. But at the end, given all these concerns and all these complaints, what are 2 or 3 things we can do today to improve your quality of life? And I think that's a helpful question to ask here, and some good advice, not just for Parkinson's disease, but for MS and other patients with chronic debilitating neurological diseases. Next slide. So we're going to wrap up with a case study here. A 45-year-old young man, family of 4, a few years ago started noticing some twitching in his right hand. He said, oh, it must be all the caffeine that I'm drinking because I've been so tired, working long hours. Then 3 years ago, 2 years after that, he started noticing some hand dexterity, typing, texting, picking up a screw, fine finger movements. He was told he had carpal tunnel syndrome by a provider, told to wear a wrist splint and his hand symptoms would go away. Then the year before he was seen, had trouble keeping up with his family during a hiking trip, and usually he was the one leading the way. And then he is referred to neurology after he had a few hours of abnormal movement in his legs, and they said, oh, it's probably restless leg syndrome. Next slide. So he came to the clinic by himself. He Googled restless legs and learned that iron deficiency and folate deficiency can make it worse. So started taking iron supplements, but on exam, there was more to it. He had some softness of speech, diminished facial expressions, including blink rate, right hand tremor intermittently throughout the history. When he walked, he wasn't swinging his right arm as much, and he had a little inversion dystonia of his right foot with walking, in particular when he began walking. And clinically, he had Parkinson's disease, and there's other tests we can do to get support, like I mentioned, the DAT scan and a skin biopsy, but you can make a clinical diagnosis of probable Parkinson's disease at this point and talk to people about treatment options. And like MS, and like dementia, and so many neurological disorders, this is a life-changing diagnosis. This is a life-changing conversation for patients. Next slide. So I tell them they're not in it alone, right? Although this is a life-changing conversation for them, that as their care team, as one of their providers will be with them for every step of the way, and that there's different medications that we can increase and start as the disease evolves and changes and they have new symptoms and new factors affecting their quality of life. And I tell them they're not alone from the provider standpoint, but also the community standpoint. There's some great resources in the community. There's some great resources online. The Parkinson's Foundation has some terrific ones through the help desk where patients and their caregivers can call on weekdays. A great library of educational handouts and books for patients and their caregivers. Weekly online events that patients and their caregivers can participate in. The Generation Study, which is, again, a great way for people to get involved with clinical research if they haven't before. And it also involves professional education for providers. Next slide. So I want to thank everyone for their time and attention today, and I'll turn it over to Casey and Cody and the team.
Thank you so much. And thank you for all the information, both Dr. Markowski and Dr. Belliston. We do have a couple questions. Now is the great time to put your questions in the question panel. We'll be happy to get to them. I'm going to just kick us off. It looks like, when is the appropriate time to refer to an MS or movement disorder specialist, knowing that my patients may have very limited access? How do I make that referral and help my patient understand this option?
Yeah, so I can start from the Parkinson's standpoint, and Parkinson's disease is very common, and we clearly don't have enough Parkinson's specialists, movement disorder specialists. I would love it if every patient with Parkinson's disease was followed by a Parkinson's specialist. Again, I live an hour, 60 miles from Boston, and it can be hard for patients to be willing to drive or able to drive that distance. I try to get my patients there after I make a diagnosis. I've started them on medications for additional opinion, and I offer co-management where they could see the Parkinson's specialist once a year, and I can then be a local resource for other visits in between. So I try to encourage my patients to also be seen by a Parkinson's specialist, but I have someone that's simply not possible. Telemedicine's been helpful in that regard, just to get additional opinion and have someone to look over all the information. And Dr. Belliston, I'll defer to him in the MS realm.
Yeah, with MS, I would say the earlier we see the patient and get them started on disease-modifying therapy, the better their course goes. None of our treatments are curative or reverse any damage that's already happened. So getting them in as soon as possible so we can get them started on something that will keep them from having further injury to their brain.
Okay, thank you. Another question that came in: how do I establish a productive connection with these specialists?
Like that. So I think just reach out. I'm always pleased to hear from different providers, and if they just send a message or call, I'm always happy to take some time and discuss with them. So just whatever you feel comfortable doing, sending a epic message or calling the office, or just reach out.
Agreed, and that relationship, grows with time, right? These are chronic diseases. Patients will see Dr. Belliston and I more than their primary care physician in many cases, right? Or every time they have symptoms, they could have a UTI or a pneumonia, but we're oftentimes the first phone call, the first point of contact, because everyone assumes, oh, it must be my MS or my Parkinson's or my neurological disease. So we just encourage patients to call when they have questions, and then we'll sort out what's medical or what's neurological, but also to be well prepared, right? To make a list of your questions, your concerns, because when you're in with the physician, the provider, sometimes you're not going to remember all the important points you want to bring up. So keep a list, write these things down, and we're happy to go through them with you.
Okay, thank you. What symptoms should make me think possible MS versus something more common like migraine or B12 deficiency?
Again, anything lasting more than 24 hours that doesn't really come and go throughout the day, or that's gradually getting worse over the course of a few days to weeks. would make us more suspicious of MS. Of course, knowing that B12 and migraines are deficiency and migraines are much more common, I think just really checking for those things are important as well, and making sure we don't miss some of the common things that are easily identifiable and treatable.
I'm sorry, I was muted, so you guys couldn't hear me. I'm so sorry. I was like, why is it quiet? So we kind of addressed this, but it's a little different of a question. How can rural providers build collaborative relationships with tertiary MS centers?
Yeah, I can start with, oh, sorry, tertiary MS centers. I will let Dr. Belliston start with that.
Yeah, so for providers, I think, again, just reaching out, picking up the phone or sending a message really goes a long way. And certainly, if they're wanting to connect, then we'll make time to connect with them.
Thank you. What if our rural community doesn't have Parkinson's experienced therapists?
Well, there's some great online resources, but there are some physical therapists who specialize in various neurological disorders, from stroke to Parkinson's to others, right? And some OTs who have a special interest in dementia, cognitive disorders. So every physical therapist can be helpful with walking, balance, exercise regimen for the patient. But it is true that there's some rehab specialists, and I happen to work at Rehab Hospital where you have several who really specialize in Parkinson's disease. So there's some great online resources for them, but also working with their local physical therapy office. Even if that doesn't exist, there's still so much benefit to be gained from walking, balance, exercise, strengthening that will really have a positive impact on the patient's quality of life.
Thank you. Thank you so much. Is there, or what is the simplest way to distinguish early Parkinson's from essential tremor?
So I see this a lot, right? And I will say most people who come in with tremor automatically think I have Parkinson's disease, right? And then I ask them, well, when do you notice the tremor? And the patients tell me, basically, if you ask the right questions, they will tell you whether it's essential tremor or Parkinson's. So with essential tremor, it's an action tremor. It's a postural tremor. When they are holding their arms out, they start to shake. When they're eating or drinking, their hand is shaking. When they're typing and working on their phone. So any tremor with action or holding your arm in a certain position and it shakes, what we call a postural tremor, that is action tremor. That is benign essential tremor. Whereas Parkinson's disease doesn't cause a tremor with eating and drinking. It's a rest tremor. When the hand is completely at rest, that's when the hand starts to shake. So I make sure patients are seated kind of with their hands in their lap, and I'm looking for this, what we classically call a pill rolling tremor, oftentimes the thumb kind of rubbing against the second and third fingers, but a rest tremor that only occurs when they're completely at rest. You take gravity out of the picture and it goes away with eating and drinking and actions.
Okay, thank you so much. I think this is probably our last question that we have time for. What's the, everyone that you put in a question, if we didn't get to it, I'll make sure that everybody gets those after the presentation. But what's the most important guidance to share with patients immediately following a Parkinson's or MS diagnosis?
Well, I'll start with the Parkinson's side, and I would say I tell them this is not a curable disease, but it's a very treatable disease. We have some very good, effective, safe medications, and that exercise is just as important as any medication any provider will ever give you. So I make sure that they get started on an exercise regimen. We have great resources from rock steady boxing classes to spin classes called Pedaling for Parkinson's Disease. And I try to get everyone involved in an exercise program early, or physical therapy if an exercise program is hard for them for a variety of reasons.
And for MS, again, not something that's curable, but very treatable, especially the earlier we meet with them and get them started on therapy. These therapies are highly effective now and life-changing and stopping relapses. So there's a lot that we can do if they come in early.
Thank you so much. We are at time, so I'll turn it back over to you guys for any closing remarks, and then I'll close us out for the day.
Thank you, everyone, for joining, and yeah, just appreciate your time and this opportunity to talk with you.
Thank you.
Yeah, myself as well. Thank you, and we appreciate you taking the time out of a busy day today, and hopefully you learned something that will help with the management of your patients with Parkinson's disease and multiple sclerosis.
All right, thank you both so much, and thank you everyone for joining us today. Don't forget that a recording will come out later this afternoon. Please feel free to rewatch or share with anyone who you think could find this information useful. Don't hesitate to reach out with me if you have ideas or topics that you want to talk about in future sessions. That's what we're here for. We want to make sure we're providing you the right guidance. And also thank you to the National Multiple Sclerosis Society for being a nonprofit partner with NRHA. You help make sessions like this possible, and education is so important, and we couldn't do without you. All right, everyone, have a wonderful Thursday. It is Thursday, yes. Have a wonderful Thursday, and we'll talk to you all soon. Bye, everyone.